Chair, I second. Gerrit Pretorius.
Thank you, Member Gerrit Pretorius. I just wanted to know for the record, Member Gerrit Pretorius, are you standing in for any member today?
I'm the chairperson of the Standing Committee on Health. I'm not standing in. Sorry? Member Seleko.
Are you standing in for Member
Member
Seleko?
Seleko.
Okay, and you also as the chairperson of Health for today as
Correct.
well. Okay, no problem. According to the ATC of, let me just call that document up. According to ATC 12 of 2023, I'm looking at the membership of the Public Accounts Committee, and I see that there's an alternate member. That member Pretorius is an alternate to the DA membership, and then member Nkondlo is the alternate to the chairperson, member Lulam Vimbi. So thank you very much, Honorable America. You are the chairperson for today. The acting chair. Yes, you have to sit here, Chair. Thank you.
The last time. Good afternoon, ladies and gentlemen. My name is Derek America. I'm a permanent member of this committee. Welcome to the deliberations of the Standing Committee on Public Accounts. So I'm going to ask the committee assistant, the procedural officer, Mr. Davids, have already established that we are corrected. So I'm just going to ask.
Honorable Chairperson, yes, we are corrected for today, sir. Thank you.
So I'm just going to ask the members to introduce themselves, and then I will ask the Office of the AG and Internal Audit Committee to introduce their teams or team. Members, over to you.
Thank you very much. Good afternoon, Chair, and good afternoon, AG and Audit Committee. My name is Matlodi Maseko, the member of the committee.
Good afternoon. My name is Nomen Gondro, an alternate member to this committee.
Good afternoon. Gerrit Pretorius, alternate member.
Have all the members introduce themselves? Thank you, colleagues, and welcome. Move over to my right-hand side.
Good afternoon, Chairperson and members of SCOPA. I'm Liesel Klue. I am the Engagement Manager on the Health Audit.
Good afternoon, Chairperson and members of the committee. I'm Gilbert Lawrence, and I'm Chairperson of the Health and Wellness Audit Committee. Thank you.
Good afternoon, members. I'm Tasneem Adams, and I am the Stakeholder Liaison Manager for the Western Cape Office of the Auditor General.
Good afternoon, members. My name is Tsepo Mutlomi, Auditor General Office, and I'm also a stakeholder liaison. Thank you.
Thank you so much. And it's one person that is just sitting out of the view of the cameras.
Afternoon, Chairperson, members. Yes, Lizette Klutter, Senior Procedural Officer.
Okay, thank you, colleagues and ladies and gentlemen. I want to just bring it to your attention that this first section of the meeting will be a closed session. It's between the members and the Office of the AG and the Office of the Internal Audit Committee. The rules of engagement is, of course, I'm going to allow the AG and Internal Audit to present the report to the members. Thereafter, I will provide an opportunity for members to ask appropriate questions where needed for clarity purposes. And then after we've exhausted our engagements, I will be led by Mr. Davids as to when we will admit the department to the meeting and engage with the department. For the record, once again, I'd like to mention that our regular chairperson, Honorable Mvimbi, tendered an apology due to illness, and therefore I am duly sort of installed for today as the chairperson. So with that, I just need to mention that this is an in-person meeting. The invitation and the notice that was sent out to members as well as our stakeholders, that this is not a hybrid meeting and this is not a virtual meeting. This is an in-person meeting, and no other parties have sort of access to this closed session of our engagement. The second session, we will have a live feed on YouTube where members of the public could listen to the engagements, and if there are members of the public present, they will also be provided an opportunity to pose a question to the department. With that said, over to you, ma'am. and will indicate if such a request had been made. So without much further ado, let me also mention that as I was just previously indicated, that we will, in terms of Standing Rule 72, provided access to the public. So I'm going to ask the members to introduce themselves, and I know the Minister and the team has a large contingent of representatives present. I will allow members to introduce themselves, and then the Minister and the HED, and then we will, as people make their contributions, and identify themselves. So I'll just let the members introduce themselves first.
Thank you very much, Chair. Good afternoon, Minister, HOD, and the department. My name is Matlodi Maseko, and I'm the member on the Public Accounts Committee.
Good afternoon, members, Minister and your team. My name is Nomen Kondlo. I'm a member of this committee.
Good afternoon, Chair. Gerrit Pretorius, Chair, Standing Committee on Health and Wellness, and alternating for Member Seleko.
Thank you so much. Welcome, members, again. So I'm, let's just run through all those who are present here, and then we take it from there. Okay, no harm.
Afternoon, Noma French Mbombo, the MEC for Health and Wellness.
Good afternoon, Keith Kluti, the Head of Department.
Afternoon, Chair and members. Simon Kay, the Chief Financial Officer.
Afternoon, Chair, Minister, members. Sadiq Karim, Chief of Operations.
Good afternoon, Chair and the members. My name is Nonhlanhla Andangosi, Chief Director of Strategy. Thank you.
Afternoon, I'm Bernadette Aris, and I'm the Chief Director, People Management. Good afternoon. My name is Laura Angeletti Dutoye, Chief Director, Infrastructure and Facility Management.
Good afternoon. My name is Santi Roy. I'm the Director, Supply Chain Sourcing, here today in capacity of Acting Chief Director, Supply Chain Management.
Good afternoon. I'm Glenn Carrick. I'm the Chief Director, Financial Management.
Good afternoon, honourable members. My name is Luke. I am the MLO to the Minister.
Thank you so much, members of the department. This particular meeting is solely directed at engagement on the annual report on certain sections only, and that is section C, and part E and part F. But before we move on to those sections, I'm going to ask the Minister and thereafter the HUD if they wish to make introductory remarks. Minister, with you.
Thank you very much, Chair and the members, for giving us the opportunity. As you alluded to, that we have been here since early morning. And if I don't speak much, it's because I've spoken quite a lot in other sections. And but with a capable team, they will be able to answer most of the other questions. But having said that, we also want to thank the opportunity for making us accounts towards the 29.272 billion that we presented in the 22-23, of which is now we are accounting what we did with that, and the specifics will be coming from the department. And also we do acknowledge that a clean audit is just a clean audit, but there are other aspects, which is we did respond and answer to some of those at the beginning of such. So thank you very much for the opportunity.
Thank you, Minister. Dr. Kluter.
Thank you very much, Chairperson, and for the members. It is indeed a privilege and an honor to be appearing in front of the committee. I speak on behalf of the management team of this department. I'm extremely proud of the department's culture, the culture of accountability, the culture of complete transparency, and the culture of taking responsibility and accountability for our actions. So in light of that, we present to you because of that culture, I believe, a very, very high level of ethical leadership. This team of people that sits with myself in this room, in terms of ethical scrutiny, can pass any ethical test that can be brought their way. We believe in ethics, we live ethics, but also because we do that, we also present ourselves to all the stakeholders we engage in the execution of our responsibility, which is ultimately to serve the public. We do it with that ethical obligation. I would really like to thank Dr. Gilbert Lawrence and the Audit Committee for the manner in which they execute the Audit Committee function in relation to our department. Our level of engagement, our level of maturity with the committee and through Dr. Gilbert to all the members. We really appreciate that level of engagement. And then to the assurance agencies that we come across with the AG, Ms. Kloo and her team, and then all the other assurance agencies that we come across and deal with. We pride ourselves that we show up in those places with the highest degree of ethics. We show up because we are responsible for the money and the resources entrusted to us on behalf of the people of the Western Cape. So thank you for affording us the opportunity to engage you. Thank you.
Thank you, Dr. Klute. And you mentioned culture, and Peter Drucker was saying culture eats strategy for breakfast. Not that strategy is not important, but the culture is more important to ensure that the success of the organization is attained. With that said, I'm just going to reiterate what I've stated earlier, that we will engage with Part C from pages 136 to 155, and Part E, pages 208 to 290, and Part F, pages 220 to 319. We will not deal with those different parts separately. I'm going to present them collectively, and members can ask questions relating to any of those parts, provided that they indicate as far as possible which section that they wish to engage with. And I'm going to, for the first round, restrict and limit the questions to 3 per member, and then we will then give the department an opportunity to respond, and we can then open for further rounds thereafter. I recognize Honorable Maseko.
Thank you very much.
Kondlu, thereafter.
Thank you very much, Chair. Chair, we are now used to the system of just present the whole sections that we are dealing with and we ask questions, and because usually they are interlinked. But I think the first thing is to congratulate the department on the audit outcome, and it's one of the difficult department also that when coming to what in Scopa we say for the financials audit in Western Cape, will always get the clean audit because you stick to the PFMA. Now we are at the level where we talk about the performance auditing to find out how can, as the Scopa, can we look into the value for money within the departments. Now, and fortunately, our partners, Auditor General, also is also looking at the performance. It's a teething. There are teething problems there that now, as we ask the questions, we'll be talking to that in trying to find understanding of the auditing for the performance. So, in the Auditor General talked on the program 2 and the program 4 that she did the auditing, and the percentage for program 2 that is achieved is 41%. And for program 4 is 44%, of which you didn't achieve 59 and 56 respectively. So the program 2 is 59 that you didn't achieve. But the question is that in target setting, because the service has been delivered, and that's what she said, service has been delivered. But now in target setting, we are trying to find out that if there's auditing that is going to happen for the programs that you don't have control, you will order the medication for a TB patient, but the TB patient has got responsibility to come and collect the medication. Now, how we are trying to find that balance of how does the Auditor General say you underperformed, where you called the patient, you went and you find that the patient now is not in Western Cape. But on the record, it will be you underperformed. Now, the problem from your side, if you have to diagnose on the underachievement of the performance, is it the way of target setting, or what can you say if you have to advise us to look into as we have the interaction with the Auditor General? Because you are dealing with the targets that there's no way you can have 100% performance. Now, how are we going to get the department in a stage where, as the standing committee, we say that we want to look at the performance auditing that also target setting talks to that? And we try to find out also the budget alignment to the target setting, that if Auditor General saying you didn't achieve, but the budget you did spend, where's the alignment between the two? Because like we are talking different languages, but the reality of it is service has been delivered. But the records, when a public person looks at the audit outcome, will say the department underachieved because it's 40 something. If you look at the 50-50, it's 40 something that you achieved, but services have been there. So if we can get, because we understand you have interaction with AG, before you come in front of SCOPA, that what conversations do you have in target setting? How are we going to make sure that the achievement, the performance indicators showcase what you are doing without us seeing the underperformance whilst you did perform? I think that will be the first chat for us to be able to, for me to be able to ask other questions if that can give the clarity. Thank you very much.
Thank you, Honorable Maseko. Honorable Kondlu.
Thank you, Chair. Can I start at section C on governance? If I can be assisted just to clarify more what you mean in page 137, unsafe care by community mental health facilities. What does that mean? In the book, it's page 137, usually. Strategic risks. Yeah. Unsafe care by community mental health facilities. If you can expatiate more about what that means. And as you say, the escalating medical legal claims, and you rated them as high. If you can give an indication, is this a risk that you are able to manage? If so, how are you mitigating this particular risk? And in what you have raised, HOD, in your opening statement about striving for an ethical environment. Now, with your 9 new cases of fraud and corruption that you have that are under review with the Provincial Forensic Services, how do these fare with the ethical environment you are trying to keep within the department? And if you can spare more about what these cases are about, what is the latest standing of these particular cases? And then I would Chair, move to maybe just for now be in keep with what Member Maseko has raised from what the AG's briefing was to us at SCOPA earlier on. Firstly, I just want to understand from the department's point of view, Program 2, according to the AG's final assessment in terms of performance, Program 2 has been rated according to AG 41%, ne? 41, and then Program 4, 43, 44, yes. So I just want to get an indication from the department whether are you in agreement with the AG about that qualification of performance of these two programs. And if so, the conversation we've been having with the AG earlier on, which I think I would like to bring to the department to also get the department's position. One is that also I see in your books you mention about indicators that are beyond your control because you are demand driven. Now, I'm trying to understand that what's the rationale of the department setting out targets that the department does not have complete control on them in terms of delivery. Because I would assume that part of the standard criteria to try and put targets is to put targets that are smart, that are achievable and within your control, because I think as the Auditor General was explaining, that you may not have control over the behavior of patients who may not come to the clinics as you would have set particular targets of visits where you would be able to dispense whatever treatment unto them. So is it wise to keep setting targets of things that are beyond your control? That's my first issue around target setting. Because if we consider what the AG is saying in terms of performance in those targets that you have set on your own, and you would have engaged, because partly we're told some are set by nationally, and I'm sure Minister and the HOD sits in MinMax and engage with this. So it's not like you are completely imposed upon when it comes to these particular targets. But the other issue in terms of this particular reality and trend we've been seeing also in other departments is that there's an issue we're trying to understand. Is a 44 or 42% performance on those indicators versus the 99.9% and 100% budget expenditure? We are told on one hand, I think by the Auditor General, and I'm interested to even get more information from the department from spending. If you can just help us to understand this phenomenon. We're told that in the main, my simple understanding or interpretation of this is that the other 60 or 58% that was not achieved in Program 2 has got no correlation with the budget. That's what it means. So if you can simplify to me what that means in simple terms, because we come back here in terms of budget, I think in the next couple of days, we will be talking about, the budget adjustments and all of that. What's the fuss of budgeting? If indeed we can sit and almost, you can achieve in terms of your budget spending almost what in terms of performance is less than 50%. So if you can just work around my simple pedestrian head around this, what does this mean, especially for an ordinary person, if we fuss about budgets and actually if we correlate the budget versus the performance, there is this particular disparity. And I'm raising this because this is something that we also had asked the AG in trying to understand. So that's my first line of questions. Thank you, Chair.
Thank you, Honourable Kondlu. Any Honourable Pretorius?
Thank you, Chair. Chair, in terms of the department's prevention plan on fraud and corruption, I don't have the detail here, but how, apart from checks and balances and apart from whistleblowers, is there any other mechanisms that are being used to be proactive and to try and prevent it from happening? Are there early warning mechanisms, if I can put it that way? Thank you, Chair.
Thank you, Honourable Pretorius. Minister, I'm going to hand over to you, and then you can then direct it to whoever you think is appropriate to the HOD, and then you will.
Thank you. Thank you for the questions. I'll just respond generally, and then the department can do the specifics. I think both these questions, they are quite philosophical in the sense that I'm resisting. I'm trying not to respond academically because that's how I should be able to respond if in terms of talking about, for example, the issue that you are talking about in regard to the deliverables and all of those, Member Maseko. But to cut short, there's a whole issue about accessibility, availability, and then you also look about the issue related to the efficiency and effectiveness. So if you have to bring, for example, school health bus to a certain school to offer packages, you will know that you will need, let's say, maybe 4 staffing, which might be enrolled nurse or professional nurse or whatever. And that school, the denominator, it maybe is about your target, that is about those foundation year, about 400. So that's what you have. And therefore, you'll need so much of whether immunizations and all of those when you bring it. If whilst you'll be bringing all of those, although you might not necessarily targeting the whole 500, because with the efficiency is about doing more with a lesser, but you want to maximize and getting more out of it. So at the end, that on that Wednesday, that bus must be there. That on that day, the other 50 of the kids, they are elsewhere or they won't attend. It doesn't mean that you won't have rendered the service, because all of them, your staffing, if the cost of bring a bus and everything on that day is about 100,000, it doesn't mean that just because you ended up not seeing as many kids that it will reduce the cost, because the service is available. There are costs attached to the availability. Now, with the issue of the accessibility, whatever reason that they are not there, that's what now the HOD said, that you use the population that out of the, you want to target setting, you'll be targeting 5,000 or whatever kids, of which is according what we have, you're supposed to have done 20 immunizations or 40 of whatever, but you didn't do it. So the issue is about when you read from the budget technical perspective, you'll say you didn't achieve, you didn't deliver much because you only immunized or only saw 50 kids instead of 100. But from the health system perspective, the availability of the service has been there and it has been costed. It is there just because they were not there. So it's another thing. So that's why we have to balance in regard to other aspects. Also, just like in the plane, irrespective whether you hardly hear the plane crash or what, always they will say, fasten the seatbelt, take out your headphones and whatever, and then you keep on asking, I've been doing this for 20 years, what for? The minute that you don't do that, tell them not to. If it so happens that there will be a turbulence, there will be quite a large number of the accident, people will be affected for not telling them to fasten the seatbelt. And yes, yet you'll find that for not probably they will have minimized even the cost of why would you need a seatbelt? Probably you have probably develop a plane that doesn't need seatbelt, or you don't need a crew member to be able to do that. But the cost of not telling them, if it so happens that it results in accident, it will be more than that. So similarly, whether you like it or not, there are services where you cannot withdraw from the system. Health, it doesn't want you to take out anything because you don't know the 50th person might need that kind of a service. So the issue in regard to the targets. The targets, indeed, in some of them, majority of them, they are not only from the national aid targets, mostly for the conditional grants, but the other targets are related to the internationally in regard, for example, the status of health outcomes for the population and all of those. So they are part of those kind of things. And then lastly, just making an example, I think I did make an example in earlier. We are hosting, like there are rugby and everything. People are gathering to watch a rugby and all of those. So whilst an ordinary people will be up and whatever, there's no budget that gives us such. But if it's happened that there is a crime or whatever, injuries or whatever that is happening there, we are expected that to be ready. But at what extent now you'll be getting those extra staff, which is they are not part of that when there is a bus in N1? Because people won't say that, Worcester, you're supposed to have planned for that. Nobody plans for that. Worcester Hospital will have their own money. But if there's a bus or a taxi had an accident there, it means that you have to have, whether it's forensic, whether the Worcester Hospital must be ready, where everyone, where does that money come from? Where does that money comes from? Because you don't get a money that sits there that just in case we have got this. It means we have to rob Paul and pay Paul in some way. There will always be. So for me, when you say district health service is one of the biggest package, the main heartbeat in terms of the health service, because it starts from the primary healthcare service to the district hospitals. They absorb many of those. So for me, when you say your target is 41%, probably from the budget or technical, if you're at a technical perspective, you'll be, you didn't achieve. But if you look in terms of the health outcomes that will have been achieved, in not only in the district hospital, but up to the community health workers, but the system starts away from the health system. So part of the contributing factors where we say it's not achieved is because we still congregate since COVID for the people not only to be counted as part of the health in the primary health care at the clinic, but we need to have wellness hubs that are outside the system where people could be seen. If it's about men's going to the taxi rank or to the churches where we could be able to render those services part of that. So that's why with the health system, you need to balance and look at the whole picture. And also, even when, like, you have a wow that is being done by the ladies somewhere, the go-go somewhere, it's part of the health system. That will have a health promoter who will be able to show them in terms of how to stay well, and all of this is part of that. Recently, lastly, Chair, in Worcester, I was making an example of Worcester, we hosted 500 women pregnant and those with the babies, 500. In partnership with the National Communications, GCIS, plus also with the municipality and also with a sub-district there. All of those, they are coming from everywhere. But the whole language is about how we can be able to improve the teenage pregnancy. And if you're pregnant, how to ensure that the children get immunized and all of those. But I bet you, as part of when we are presenting a part of the plan, there was nothing that says we'll be hosting 500 young women with their children where we have to bus them, because most of them, they're from the farms. But the things when you talk to the epidemiology, there might be outbreaks. All of a sudden, something needs to be happening now. It's happening. There's a typhoid, there's a whatever. You shift like now, there's a measles, a rubella, whatever, German measles coming there. Things you cannot be able to plan about these, but when it happens, we don't have a policy that says that, let's reflect that how much you were given at the time. It doesn't work like that. So you have to be able to do all of those things. So lastly, there will also some of the areas, talk about epidemiology again, we'll find that it will be influenced, not only about the weather, like now we had the storms, with the floods. Nobody knew. Of course, it does impact also on other sectors. But the issue of where you'll find that the Groendal in Franschhoek, the access to whatever, the clinic in Worcester, where there was those kind of things, nobody knew that there will be no roads going to Hermanas or we have to whatever in the Overberg. Whilst the others, they could be able to say, oh, it's raining, we're not going to build the houses, whatever. For us, you can't. You have to make sure that there are no roads coming here. So where are the people of the overbag? Where will they gonna go to meanwhile? So it's a whole thing about, you don't only look at one system, because we're talking about financing, but for the strength of the health system, we have to look at other building blocks, the human resource, the leadership, we're talking about the health financing, the issue-related information system, about 5 or 6 of the building blocks. You don't look at one thing, all of them. There shouldn't be any weakest link. So the target is crucial from the budgeting point of view. But for us, it's about, you have to look in terms of the thing, whole holistic. But the details, Dr. Kluti, over to you. Thank you.
So thank you very much, Chairperson. Thank you, members, Masego. And I didn't get your surname, Nkondlo. Yeah, member Nkondlo. Thank you for those questions. So let me start with the ones, and I'll come back to the targets in the budget. So firstly, thank you for the congratulations for the clean audit. We, like you, and working with the Auditor General, we are very keen to understand value for money. That's a process, and it's a process we're starting with the Auditor General. I can tell you that we're the only health department in the country that has had a clean audit ever. And we've had it 5 times in a row. So we don't take that lightly. So on moving towards value for money, it is an important process to start interrogating exactly the questions you're asking. And I'll give you the national context for these questions, and I'll bring it back into the province to contextualize what Minister started explaining to you. But before I get there, let me then just talk about unsafe mental health care facilities, Member Nkondlo. Basically, it means we have community-based facilities where people with intellectual disability are being admitted and being cared for by a non-profit organization in a community setting. We have a licensing unit, and the licensing unit is in our provincial department. Part of what they do is they go to every private health facility and check whether they are operating within norms and standards. And therefore, the licensing unit must also make sure that community settings where NPOs look after people with intellectual disability also have the norms and standards in place. The reason why we rated this risk as high is subsequent to the Life Esidimeni debacle in Gauteng. The national regulations has significantly been raised to very high levels. Our concern was and is that the community structures has to do so much to be able to live up to these very new, stringent and high regulations. Hence, we registered it as a risk that many of our community-based settings are not in a position to meet those big requirements for licensing. So we're managing it, and I will just want to put to you all of those 14 risks that you see there. When we are giving the risk as a very high rating, we escalate it to our senior management meeting, which I chair once a month, our senior management meeting, and we assign a senior manager to be the risk manager, and we take a monthly report on whether the risk is being mitigated as a senior team. This is one of the risks that we then manage on a monthly basis. And the long and short of managing that risk is we're working with all other government departments. So we're looking at public works, we're working at local government, we're working with municipalities in terms of their requirements for fire regulation, all the regulations that they have for people to be, for a non-government or non-profit organization to be housing the clients that must get the care. At the same time, we have very clear, strict requirements of what type of care must be rendered, and we then manage it accordingly. So we have a project team that's systematically, on a monthly basis, going through how many organizations are there, how many of them have applied, how many has been assessed, how many is not meeting what requirement, what do we need to put in place to mitigate, assist, and put that in place. So that's just a context for managing that, because we take it very seriously that none of the people that must get in that care in that setting must get compromised care. So from a care perspective, we can proudly say to you, there's not a single one of these non-profit organizations that gives suboptimal care. Our requirements, our concerns is that the conditions that they have to meet in terms of electricity certificates and all the other infrastructure issues are things that we're working through. But that is the case for that. In terms of the 9 cases, for fraud, we have the detail of all 9. Again, we take our pride because we meet with the forensic service guys. They meet with us quarterly. And we have been able over the last 2 or 3 years to work through all the recommendations. We've been able to work through what exactly we have in each of these cases. So that's the ethical standards you're asking, but also whether we're having proactive measures in place in relation to forensic goods. So Mr. K will give you the detail of all of those 9 cases. We have them one by one, and you will have a sense from that what is currently being raised under the 9 cases. We have a very stringent process of investigation, and many of the cases actually referred by us to the FPS. And it's us saying we suspect something's happening there, investigate it and close it, so that we can close the loop of all of the investigation reports, action the things that needs to be done, discipline where it needs to be done, even open South African police cases. If it has to be against our own staff members, that's the process we follow. So we have a zero tolerance for fraud, and that is the process. So if Mr. K can just quickly go through that, I'll come back to the target setting chairperson, if that's okay. Simon.
Thank you. Thank you, Dr. Kuti. So out of the 9 cases, 4 have been self-referred by ourselves to PFS for investigation. 4 have come from whistleblowers and 1 is a tip-off. So anything within the whistleblower or the tip-off, FPS has to investigate. If there's a direct report from ourselves, there's probably some smoke and fire. So examples of falsification of medical certificates, manipulation of procurement processes in a couple of places, manipulation of IPS to favor suppliers, procurement of ICT hardware, allegations of BEE fraud, leaking of confidential information, an allegation around fraud involving a security service provider, and the last one is an alleged sale of confidential patient information. It's quite a broad church. It's not just financial, and obviously on a quarterly basis we monitor these very, very closely with the FPS team. Thank you.
Thank you very much, Simon. So each of those 9 cases, as you know already, 4 of them we picked up something that we worried about and we're referring it. I can tell you all the preceding cases that has been closed that comes to us. There's a final report. There's a recommendation of SAPS. There's a recommendation of formal, and we've gone through each of those and closed many of those cases. In many cases, dismissing individuals that's been found guilty of this. So these 9 cases, when the substantive report comes back, they will be dealt with in accordance with what is the zero tolerance we have for corrupt practice. Obviously, we afford people this opportunity. Then I think the question you asked, member, is whether we have a proactive system in place and just waiting for this. Obviously, the fact that we have referred almost 50% of the cases already show you we are proactive. But in addition to that, we have in our financial checklist on financial procedures, and why we probably have those 4 cases is Mr. Small and his team have what we call a internal audit or internal controls process. So each transaction needs to go through certain things. We have a team that goes through all of those, pick up whether all the things have been followed. And if we follow something untoward from there, we trigger a specific action in regard to that. So we're not waiting for things to happen. We have systems, we run the reports, we look at all kinds of things to be able to tell us that there's red flags. So our fraud plan and corruption plan is very much on our own diagnostics to say that we pick up, let's call it deviation of practice. And if there's a little bit of a smoke, we dive in, we check. And that's why 4 cases was referred. So let me come back to the key question of the budget and the targets and performance. I would like to separate them into those 3 things. So let's start with the budget. The budget is allocated, and that's why if you go to the end of program 2, and I'll explain to you what you see at the end of program 2 in our report. Because at the end of program 2, there's a table that says linking performance with budget. Now, the first thing I have to say to you, we have allocated this budget according to program 2.1 to program 2.9. So there's a big allocation for district hospitals. Then there's a big allocation for clinics, and there's a big allocation for community day centers. There's also an allocation for district management offices. So the first thing is the budget that gets spent to 99% is because those entities do the work for which they are employed. So they see the patients, they do community-based outreach, they manage effectively because that's what the management team is supposed to do. They fill vacant posts when need to, they fix things that needs to be done. So you have a functioning system because the money is spent to give you a functioning system. None of the indicators, and this is the key question around budget. The sophistication of these indicators, and it's a global phenomenon. The money you put in for your inputs to do your service, it's extremely difficult to track that money to an exact performance indicator. And if you have to go and say, for a district management team, which we spend 2% of this budget for, the indicator here, which is a provincial prevention plan, and the total satisfaction of clients, and the patient safety closure rate, and the severe adverse events, and ideal clinic status, those 4 things does not even touch 5% of what that people in that district management team does to do their work. Now, if we had to tell you everything they do and had to bring indicators in here to track their performance, we would have 100 odd indicators just on that first one. So just to indicate to you, so when we choose an indicator, and I'll come back to the indicator part, to choose indicators to give you what the money is spent for, you know, and that exercise would be such a, I know some people have tried it in the past, but to try and tell you for every line item and for everything that we've got, what is indicated to tell you that you've actually done performance, it would run into multiple pages of indicators. So firstly, to track the budget to specific indicators is virtually impossible. It's a global phenomenon. It's not something of the Western Cape Department of Health's doing. So this thing that the budget translates to indicators and translate to performance is not a direct correlation. If you had asked us to do a direct correlation, we can go back to you and tell you that this is what the money was spent for. This is what you get in return for the money. It's not the indicators. So let me come to indicators, which is your second issue. The indicators that is chosen here are indicators that is chosen by the sector. Minister Mbombo, myself, are part of the National Health Council meetings. I've registered on multiple occasions. My predecessors has registered on multiple occasions that the current indicators that the sector choose is inappropriate for the performance of the healthcare system. We're on record. There's a process that starts again now. So they are coming down to consult, and they're going district by district to consult on these indicators. You ask our public health specialists, they throw out 90% of these indicators. And they will tell you that more appropriate indicators are the ones that should be in place, which in itself, if you just had those indicators, it would still be 10% or the tip of the iceberg of what your performance is, but at least you choose the ones that is greater in terms of impact than the current indicators that's chosen. So the indicator process itself is flawed because of how it's selected. The Western Cape input, and then we show that to the Auditor General, and Liesel, we will show you again. Our input into drop that indicator, drop that indicator, drop that indicator with motivations of public health specialists of why it is a bad indicator and why it is not going to tell you anything and will give you the kind of results that we're getting here, because it's neither here nor there in terms of your overall performance. And we did it again. We will submit it again for this round. Hopefully, we registered it with the National Health Council, and I registered 2 things with him. I said, please, let's use this opportunity with the budget cut that we have now to completely reset the way we do planning, the way we choose indicators, the way we choose data points in terms of that. So the indicators itself is a flawed process. And the number of indicators that we've added as a province, we've reduced to a bare minimum because it is very difficult to link these indicators to performance. Not that we don't appreciate that you asked the question, because it's important that we do answer the question. And we need to go back and do the hard work to come back and then come to you to explain to you what in our estimation would be good indicators. So that is targets and indicators. Now, the second part about the indicators is it's whether you choose the right indicator. The second part is setting a target for that indicator. Now, we have, and we've got our little thing in our program too, which we explained to the Standing Committee this morning. We have an indicator here that says whether we've achieved an indicator, according to our convention, is how many we've achieved. Then we say whether we've partially achieved. And that is whether we've achieved between 50 and 95% partially achieved because of flexibility and unpredictability. Then we say not achieved. Now, according to our convention, not achieved is then much lower than what the AG does, because the AG is saying, well, if you've not achieved it, you've not achieved it. And that's where the 42% comes from. If you take our convention, which the AG then looked at, we come to 90% of achievement, because for us, partially achieved in this flexibility is as good as having achieved the indicator. But we respected Liesel and the team when they said, you can't take partially and say that's achieved. The not achieved on our is less than 10%. So according to us, we've achieved and partially achieved more than 95% of these indicators. That's our convention that we've done. And then I'll bring you to the last thing, because I'll use one example because it is a ludicrous example. Imagine we sit in February and we tell you, oh, we think 2,300 children is going to come with diarrhea to our hospitals. We got no idea who's going to come with diarrhea to the hospital. But we have to predict it according to this indicator. Now, if we say 2,300 children came with diarrhea, and then only 1,500 came, you're going to say we underachieved. We're not going to make diarrhea in the community. It is how difficult it is when you choose an indicator like that, because the indicator is completely not up to us. Whether children, whether there's somebody that messed in the water pipe didn't come through, that will determine whether somebody gets diarrhea. Not whether we as a health department say somebody's going to get diarrhea. So that is just one example, and I can go through all, I will bore you if I go through each one, because I've just went through each one of them again, and that's what we explained to the Standing Committee this morning. We can go through each one. In our estimation, that brings me to the third point, because the third point is, what is then performance? As I'm saying to you, the budget is, we spend the budget to get the job done. I'm saying to you, the indicator system and the target system is completely flawed. We've registered it with National, we've registered it with the AG, right? And we're walking apart with the AG because we're saying to them it's an important thing to solve. Then I'm saying to you, so what is performance? And again, I come back to what is performance is whether the core things that we're supposed to do gets done. So when you say what is performance, did we close our hospitals when somebody needed an emergency to come in? No. Did we pick up people that phoned an ambulance? We might come late. We picked them up. Did we make sure that people are in a hospital was not turned away because we said we were full? Even if they had to lie on a mattress, as we explained to the Portfolio Committee this morning, they got the care. Ultimately, the members of the Portfolio Committee asked us, or the Standing Committee asked us this morning, so how do you measure what they called excellence? I'm hearing what you're saying. How do you measure performance? We believe it is to say, that our core mandate is to render an ambulance service. Did we do it? How well did we do it? Our core mandate is to say we must run clinics. Did the clinics operate? Our core mandate is to say emergency centers must be there for anybody with emergency. Were they there and should we do it? And maybe you're challenging us so that we can actually pronounce ourselves on performance. And maybe that is what we should do. So I really like the way that you ask the questions. You are asking us and challenging us to go back and do that. We will do it responsibly with the audit committee. We'll do it responsibly with the audit general. But more importantly, we'll do it in the sector with the national department. And we will show all the documentation and motivation that you've given us today that is the right thing to do to challenge those processes. Thank you, Chairperson.
Thank you, Dr. Klutse, and thank you to our members of your team who have contributed to the responses and to Minister. In the latter part of your response, you made reference to the AG, and usually the AG does not wish to participate in this part of the meeting, but if there's any comment that the AG would like to make, now is the time.
Thank you, Chairperson. I think what the HOD has said now is exactly what I tried to convey in the closed session as well, especially relating to the budget versus budget spent versus targets achieved. So yes, the comments from the HOD is noted, and I'm fully in agreement with those comments. Thanks.
Thank you so much, Ms. Clear. I'm going to open the floor for follow-ups. Honourable Mseko. Honourable Nkondlu, follow-ups.
Thank you very much, Chair. And again, thanks, Minister and the HOD. I think from our side for the follow-up, it's what we are saying, that the page of the performance from the Auditor General also, as they have a control of what to audit, they have to also look at it, that are we auditing? Are we going to give the right information in auditing, or is going to be something that will spend a lot of time from SCOPA trying to have an understanding of the outcome? Because when you look at what is being audited, it's like this. I love the analogy of Minister, of the plane. So they audited whether people were listening to the air hostesses to put the seat belts or not all the people that put on the seat belts. To us, we want to know the messaging. If it reached the people that they did put on the seat belts, then we know if there were 250 people in the plane, yes, 250 people they did put on the seat belts. That you can look at the indicator, whether that happened or not. But whether they were listening and say that you are going to audit whether they were listening, there's no way you can do that. And that's where it is a problem to us on the auditing of the performance from the AG, that why do you audit whether people were listening or not? That they don't have a control of making sure that people were listening or not. So that is the case from us, that we are trying to do that. But that's the comment from me, Chair. I think I've got another question. If the members have got the follow-up, I'll wait until it's the time to ask the questions.
Good, thank you, Honourable Secretary. Yeah, maybe you should ask also how many of those passengers survived the plane crash. Honourable Nkondlu.
Chair, this discussion is becoming even more interesting. This post-facto discussion. It's a very interesting, as you had to say, Minister. You start academic, philosophical, and perhaps, Chair, we may not resolve. Let's accept the responses as the colleagues have said, and hopefully they take these comments into their future planning, because, Chair, I think it's just making our work very difficult. I must state it up front, because we've got a responsibility to oversight here. And I think, whilst I accept HOD and the Minister, that you also have a responsibility to explain and account. The Auditor General sets particular parameters from which they must be able to measure your performance. So if we're sitting here as three different stakeholders and we can't have a simple agreement on how things got to be where they are, I can imagine of a citizen. So surely this concept of sophistication and complexity, if it can't be demystified, then we are running, I don't want to use the term, which we used during our break, because it would be unparliamentary. Because we're running serious business of taxpayers. But I think what is becoming very clear is that, this thing we call a sophistication, in simple terms, it's really getting out of hand of all of ourselves. Because from where I'm sitting, HOD, with the explanation that you have given, and without in any, a place from where we are coming from to try and create spooks in the department where they're not. We're trying to understand information that is presented to us on the basis of how the information gets to be presented. And as you say, it's standard, but also it is standard to link performance to the money that you spend. It is practice because you must justify, as you say, value for money. So it's either in the planning and how we're setting things, there is something wrong. You said indicators are flawed, and I was very scared that we get to this point with all of these indicators that have been in these books, and at this point where we are concluding and declaring them as flawed. So it really means that somewhere, somehow, not here, not in this process, we would needed to have resolved those problems, because when they come here and the information of the Auditor General, as we said, sends conflicting messages. It's conflicting if you say the department or the program that I have audited have achieved 42% of the set indicators in terms of performance. But you still are able to say, no, you must understand. If you look at this and this and that and the other, they have achieved. So I'm just saying, and we have said this to the AG. So I want to conclude, Chair, so that we don't get into a conversation that would not have an ending. That perhaps into really the future planning and the conversation that the HOD said they are having with the other parties as they are preparing into future, they must take into cognizance, because we are not going to move based on the explanations that are being given. For me, until, and I'm asking the question as somebody who sits in budget, what's the fuss then on budget if somebody says to me, no, actually there is no correlation. We can spend 100% of the budget whilst we can achieve less. Somewhere, somehow, that conversation really, maybe not in this meeting, Chair, maybe in the resolutions of SCOPA, we need a serious conversation about the correlation of the two. It may not be straight, HOD. It may not even be that much close, but surely if we are saying we are investing resources of the state, both financial and non-financial resources, somewhere, somehow, we need to understand how these two get to come together. So I just wanted to stop there in terms of that conversation, because I could see that we may not necessarily, I think it's that thing in my other NGO, we normally say, let's agree to disagree, so that we can live, or else we're going to sleep here. But the point I just wanted a explanation on, which I think might have been missed in the questions I've asked, was the medical legal claims. And I think I picked up in page 305, in page 284 to 285, the issue of these medical legal claims, which some already in terms of the contingent liabilities are already there. They've been confirmed. Others, I think you are indicating that because some of those claims you cannot already by now be able to quantify, as others are still under assessment in terms of contingent liabilities. I would just want you to give us just an indication about these legal claims, because it seems it's something also in your risks that you have indicated as a higher risk there, as you were indicating. So I think for me, Chair, I wouldn't go into the other issues. I would just want to just understand this issue of medical legal claims, which are in the risks, but also I think in the contingent liabilities. I think there's already some figures that are indicated, and they've actually increased from the last financial year. Thank you.
Thank you, Honourable Nkondlu, and thank you for the concession you've made, so that we all go home tonight. I'm going to hand over to the Minister. If the Minister would like to respond to Dr. Kluter.
So thank you, Member Nkondlu. Thank you, Member Masego. Just to conclude the matter on what you just said, is maybe just to clarify when I said that the choice of indicator is a flawed process. It's how we choose the indicator. The second thing is the choice of the method of how we set targets needs attention. What we are extremely proud of is that the Auditor General looks at the data that we use and what we report on, and the Auditor General pronounces on the credibility of the data. So that's very important in the clean audit, especially for predetermined objectives, that the finding is there's no major findings on the data, the quality and the credibility of the data. So I would just like us to not make that, to conflate the two, because the data is credible. We work within the parameters of what has been given to us, and the data is credible. So what you see, and the Auditor General saying the data is correct. So there's no fudging of the data. I'm talking about the process of selecting the indicators and selecting it credibly for the complexity of what it is we want to do. But I also agree with Honourable Nkondlu that we then go back and say, so what is our position on performance? What is our position on these things? And nothing stops us from making a statement as a department in relation to that in light of the conversation. But also just to say, because you raised the issue with us, it helps us on a formal basis with the processes to follow through, because this is not a new issue. It's been around for a while, and it's good that it comes to it so that we can actually deal with it decisively as part of a broader sector. So I appreciate that comments. Just to come to the medical legal claims, again, our process in this department is we have a medical legal claims team, and the team is consistent of people that works in our department, together with the State Attorney Office, together with legal services in .P. And actually, our team and our model has been benchmarked as the benchmark for the country. Other provinces are trying to follow that model. So with this team of people, what do they do? Because if you do, and me and Minister Mbombo was part of a national standing committee on medical legal claims about 3 weeks ago. The medical legal claims that the claims that are instituted and the payments that are made in this province is minuscule compared to what happens in other provinces. So we're not saying that you must compare us. We're saying every claim for us is important to manage and the process. So what does this team do? A claim comes in from an aggrieved party via their lawyer. It gets assessed by this team. So firstly, what we do have is the issue of missing records is not a big issue for us. We invariably have the medical records. We can look at the claim, we look at the records, and the team decides, because we have a doctor and 2 doctors on their clinical team, can decide on the merits of what the complaint is about. And to say, is there merits to concede? One of the things that they do when the claims come in and merits to concede, they then have an engagement with the lawyers of the aggrieved party, and through mediation, actually say, look, we don't have to take this thing to court. Can we settle? These are the things, this is what we do. Now, in that whole process that they do, we then have a clear understanding at any given time, how many claims are active that has come over a period of time, how many claims are being processed and negotiated with the claimant's lawyers, and therefore, based on that, what is our predicted, what let's call it, almost like a projection of what we are likely to pay out. Then we budget accordingly. So what Mr. K will do is just tell you what exactly those numbers are and where we sit in terms of that bigger system. Mr. Gay?
Yeah, thanks, actually. So it happens in a couple of places in the financials, and while we've got it at risk, the first page is page 298, which shows us the actual expenditure year on year, which has gone up from 64 to 163 million. But again, there's a story in that, because at the end of 21-22, there were a number of cases that we had anticipated to settle in the 21-22 year that rolled over into April and May of the 22-23 year. So we actually had an under expenditure in that line item in the 21-22 year, which we then used in the adjustment budget to top up this current year's budget. So it's a timing difference. Then there are three other places that you'll find it in. You'll find it in contingencies. You'll find it in provisions, and you'll find it in payables. So our convention is the following. If you're going to find it in a contingency, there's a possibility of settlement. And in fact, we generally keep things out of contingency because we like to, if we're going to settle, we like to record. If we're not going to settle, we're not going to record it. Then you'll find it in provisions where we've conceded the merit. So there's a case, but we're not quite sure what the final amount is going to be. So there's a bit of an estimate that sits in that space, but we haven't quite yet determined what the final amount is. And then in payables, we know exactly what we're going to spend. So whether we've arrived at a settlement or there's a court order, they're very seldom are there court orders because we choose to settle in those spaces. And the reality is the trend in this country, and we are not immune to that trend in this country, is that the medical legal claims have been going up, both in numbers and in terms of quantum. And therefore, we do need to keep, from a financial perspective, we need to keep both eyes on that provision that we create, or the budget that we have, because you can imagine if we have a large settlement that comes over, it can really destabilize our cash, our budgeting, and our ability to balance up our books. So that's really where it sits, and that's why we have it as high risk. But again, there's also there's a combined assurance framework that also sits. So there are numerous clinical meetings and clinical quality assurance meetings that happen to look at adverse events. There are teams that sit at the hospitals assisting the medico legal team in assessing the merits or otherwise of the case. Then we also have a very good relationship with legal services in the province, and then the state attorney in this province actually has dedicated resource to the department to be able to assist us in defending. And one of the good things that the system of control that we've got means that the chances who take chances elsewhere in the country don't come down to the Western Cape, because it's not worth their while trying to take a chance, because we stop them in their tracks. And that's one of the reasons why we are able to keep it down. But the reality is that there is an upward pressure, which is what we're accounting for in the risk. Thank you.
Thank you, Dr. Kluter. New question, Honorable Masiku. Okay.
Thank you very much, Chair. I just want to find out on page 211, there are the late or non-payment of suppliers. If you can, I can find the reasons. The reasons is misfiled, misplaced, unrecorded invoice, which is it's something that you do have control in. What are the reasons for that? What are the loopholes that are allowing that? And maybe the interpretation of, I don't know, what does it mean on the redundant stock when you go up on the other material losses written off on the redundant stock of the CMD and HIV/AIDS? Is it the medication that has expired, or what is that? What does it mean, and why such an increased amount from 18 to what happened there? And also on the government vehicle damages and losses also. So that graph, both of them, if I can get the explanations of what happened there. And also the last one that doesn't have page there, the Auditor General talked about the supply chain management the regulations that were not followed from the department. I'll call it that there is a deviation because the service also is it's been delivered, but the officials didn't follow the supply chain. It's under what circumstances that that deviation will happen, that the officials don't have to follow the supply chain management regulations just to get the clarity of those circumstances. What circumstances are those? And I asked this question to the AG that does she identify that as an emerging risk or not? Because if there's a loophole where that can happen, maybe the numbers can increase of that supply chain management not regulations not being followed. And if that's the case, that because there's a dire need for that deviation, why there's no policy from the department that can be developed for that to happen, that it doesn't follow, it doesn't go to the side where it's supply chain management not followed. It becomes another policy that chips in for that deviation for it to happen, because we're dealing with health. So anything can happen that can say you have to shift from Paul to go to Paulina to make sure that the service is redirected to another community or whatever condition that is happening within that point in time. Chair, that's all from me.
Thank you, Honourable Maseko. Any other member would like to pose any other question? New question? To be the last question. Thank you, Dr. Kuze.
Thank you very much, Member Msego. So there's a few issues that you raised. I'm going to ask Mr. K just to touch on that first description of these items that you have on page 211. But then there's two other issues which I would like Ms. Roy just to touch on in terms of supply chain process not being followed, but products delivered. And I'm not sure whether you want Mr. Carrick just to explain this whole thing about the definition of irregular expenditure. So we just leave that. We should probably do that as well. Glenn, if you can just prepare yourself in terms of definition of irregular expenditure. But Simon and then Santi.
Thanks, HRD. I mean, the reality is we're never going to be 100% perfect. We have 196,000 transactions. The 0.06% don't get over the line. And there are a number of reasons for that. I think some of the major ones are around system errors, banking details. Yes, sometimes invoices do get misplaced. And then we have to go and find those or get them coming out. And then the reality is we work in an incredibly decentralized system. We don't process any significant number of invoices at a central level. The hospitals and the districts and the sub-district offices and the district hospitals, they process their own invoices. And that also then links to some of the questions around why there are deviations, because again, we're such a massive organization. There are so many different users that the simple reality is not everybody's going to get it right all the time. And we have to make, and sometimes when it comes to an emergency, we have to make a decision at that point in time about the urgency of the matter and what procurement process we're going to follow. And sometimes people have different opinions about that. And then we have to follow the irregular expenditure framework to be able to manage those particular things. I think the one thing that, and actually, what is very important is about the behaviors and the culture of the organization. So we have to disclose every year all supply chain, all finance people, all deputy directors, and all SMS members, regardless. We all have to do our financial disclosures. Now, I know we're not dealing with this particular period, but the one that covered this to June this year, 100% of everybody submitted their disclosures on time and correctly. That in itself tells a story as to why we've only got 6 million rands worth of irregular expenditure in a budget of 29 billion rand. 6 million rand is still a number, and we've got the breakdown, and we've got line listing of this. We've got processes that we go through. We follow the combined assurance framework. So we've got our managerial oversight, which must do what they need to do. Dr. Kluti mentioned that we've got the DCUs, which is our own internal assurance. Then we have the Auditor General that comes in. And sometimes we find one of our biggest single item in irregular expenditure this year was because the Auditor General didn't believe that how our facility had treated it warranted it to go through emergency procurement. And that's okay. There's a lesson to be learned there. There's a value for money assessment that has been done in that particular space, and we will learn from the mistakes that we make. That's part of the culture of a learning organization that we continually find ourselves in, and all of us are incredibly proud to be part of that organization. So we take our clean audits with pride because it's about a system that we've built up. It's about how we behave and how we interact. People make mistakes. Our philosophy is it's okay to make a genuine mistake. Don't come with a fraudulent mistake. Then, as Dr. Kluti indicated to you, we will throw the book, and we have thrown the book at people, and we dismiss people. It's not a problem. We report people to the police. That's not a problem. But if you've genuinely applied your mind and you've made a mistake, we don't want to come with a big stick, because that's when people start to hide things because they become scared. And that is not a culture that we wish to inculcate within our organization. We want to be open, we want to be honest, we want to be transparent, and we want to allow people to make mistakes and to learn from those particular mistakes. And that's, for me, the core essence of why these indicators of financial impropriety are so low, and why we feel comfortable that we can manage and mitigate where the risks arise. Thank you.
Just going to ask Ms. Roy just quickly to speak directly to the issue of supply chain, and then Mr. Carrick is quickly just going to tell you about the definition of irregular expenditure.
Thank you, Dr. Kluti. So I'm answering on the assumption that the deviations to which you're referring are the pages 212 through 218. So a series of lists. Okay. So I'm going to frame it on that assumption. So the principle, and I think that very, very importantly, is that we apply competitive procurement first and foremost in all instances. So as a matter of principle, we seek to not deviate from any of the regulatory prescripts. When we deviate, it must be provided for either on a national or on a provincial level, or through our own policies. So the emergency procurement delegations to which Mr. Kay was referring are provided for in the National Treasury regulations, but enacted through our own policies. And there are similar mechanisms allowed for what we call limited bidding or extensions or expansions of contracts. So there are very defined guidelines to which we have to adhere to allow for those deviations from the principle of competitive procurement. But I think it's also very important to emphasize that in any of those instances where deviation takes place, there is oversight provided by a series of committees, depending on the value of the transaction, depending on the complexity of that transaction. And then the relationships that have already been referred to with internal and external assurance providers. So within the department itself, there are 3 separate entities which provide internal assurance, of which the devolved internal control unit is one, my own team is another, and a directorate supply chain governance is a third. So we are always monitoring and balancing each other out, plus our external service providers, including the Auditor General and the internal audit unit. And between the relationships among those assurance providers, we manage to limit those deviations as far as possible. Thank you.
Afternoon, Chair, members. Yeah, so irregular expenditure is simply expenditure that has been incurred not in the manner prescribed by legislation. So it does not mean that we've incurred a loss or fraud has been committed. To give an example, it could be a case where the right item was bought, but the incorrect rank approved the procurement thereof. or the supplier that we purchased from, and in some cases we have sole suppliers of critical medical supplies and medicines that refuse to be registered on the required databases, and we have no choice but to incur that expenditure.
This is one part, which is the issue about the redundancy. Sorry.
So coming to the redundancies. Again, we're a large organization. We've spoken around demand-driven services. And the reality is certain consumables, certain medication do expire as best as you can try. We have had a bit of an increase year on year. The primary issue was around HIV self-test kits. We ordered about 900,000 rands worth of those through the conditional grant. And the reality is the demand never came through for those kits. We've also got some issues around some of the COVID stock. So we have a non-pharmaceutical warehouse. We had a lot of specific things that we thought we needed for COVID. Now that COVID has dissipated to a large extent, we're having to go through a process to write some of that off because it's no longer fit for purpose. And so we will see some coming through in this, but 1.3 million and goods and services budget of 9 billion falls within an acceptable parameter in terms of what we've been doing. Thank you.
Thank you, Dr. Glitter and team. Colleagues, final comments and questions? Okay, good.
Thank you very much, Chair. I just want to, it's just for our info to have an understanding, the meaning of the ideal clinic status, the percentage. When you talk of the ideal clinic status and you said the percentage of 79, in my head I'm saying you want to excel in the clinic, in every clinic. So why is 70 something percent for that? So if we can have the meaning, what does it mean for me to attach that percentage to that? And the other one, it will be, I mean, the census came out now on 7.4 in Western Cape. So I want to find out from the department for the human capital reacting to, as you look, the population. When was the last time that your organogram is talking to the demand within our health centers? And I know the budget constraints. So I've been asking this question to each and every department about the services that looking at the budget constraints and the workforce that you need to service the census that we see now that we are about 7.4%. Where are we? When was the last time we updated the demand within the province? Two, there is a report that there is the provinces, the patients that come to Western Cape for the medication in different health facilities. And through the GDP, the allocation, it allocates in the province where each and everyone they come from. In the MINMEC, do you see having the conversation of invoicing in the health facilities, that if I'm going to come from Gauteng or let's say Northern Cape to come and get my chronic medication in Western Cape because there's no medication in Northern Cape, will you see having the conversation of invoicing for me because I've got an ID, for the money to follow me where I'm getting the treatment in different provinces? Do you see us getting in that space as we look at the financial constraints that are there, the budgetary, because every cent counts now. It's the same like in the principle of the school. The kids, they've got their own identification from school to school. So if they come to Western Cape, surely maybe there need to be a conversation of the money that was allocated in another province to follow the child where is attending the school for this financial year. do we foresee us having that conversation within the different departments of our allocations in the GDP are following us as the population? Chair, I promise you, that was the last questions from me.
No, not my problem. Anyway, thank you, Honorable Masiko. Dr. Kruger?
Thank you, Member Masego. And let me start with the first one, which is the ideal clinic status. So ideal clinic status is of the facilities that was assessed and how many of them achieved ideal status. So you'll find it in two different places in the report. The one that we discussed at the standing committee this morning was the one where we had 84% attainment. I understand the one with the 70 odd because that includes the city of Cape Town in the denominator, and that's the total one for the province. The long and short of it is that there is a checklist, quite a detailed checklist, that somebody comes with 6 different domains. The checklist is like an internal assessment for the ideal clinic status, because the Office of Standards Compliance will use the same domains, and they come in and they do their assessment and then give you a certificate whether you meet your certificate. And the scoring is you need to score a minimum score against all the elements in it to get the ideal clinic status. So for us, 84% of the provincial facilities is something that is on the increase. And we worked out this morning and told the standing committee that there's 28 facilities, which we know by name, and why they did not get the ideal clinic status for us as the Western Cape government. And it's small facilities. It is mainly related to infrastructure, and it's mainly related to having things that is very difficult to ensure in a small facility. But for compliance sake, we're weighing up again. We're trying to look at the criteria, engage our national colleagues to say, look, do we really have to get this thing in the small facility if it's not going to be used, more than once a year? But be that as it may, we know exactly why those have not got status. All of our teams in the districts take it seriously. The idea is to get 100%, 100% ideal status. Obviously, the city of Cape Town does it themselves as well, and we work with them. Together, we're trying to get to 100% ideal clinic status. There might have to be us engaging with our national colleagues to reset some of the criteria for very, very small facilities to be able to achieve that. So that's the one thing. The second thing is a very important question that you're asking in relation to the equitable share and the formula. So I'll ask Mr. K to give you the technical answer on that specific issue. In broad terms, the financial reality that we're in for this financial year, so this is now starting in 23, going into 24, is that we have a significant shortfall of financial for this year. We obviously have to go through a budget process. We are tabling an adjustment estimate in the next 4 weeks. And we need to understand what's coming through that process with National. Be that as it may, Mr. K can explain to you how the allocation formula from the centre has affected the Western Cape as opposed to other provinces. So that's the second issue. In relation to the third issue, we have a process where if a patient is referred from another province to this province for care that the province does not offer, the other province does not offer, it is a policy which means it has to be a HOD to HOD referral. And there is a national standard operating procedure for claims, but that is if somebody is in Eastern Cape or then Free State, and it's a highly specialized thing. They don't offer it, and it comes to Grootskeur, and they come to Tygerberg to get that service. Many of those is that there is an allocation for level 3 services in those provinces. So there is a question to be asked. If you get the money to render that service, why are you sending them to us? And that's why the standing operating procedure is for us to have claims for that. The difficult part is we don't have claims for, let's call it, ordinary services. Where people are just coming to the province, and we know that there is a big proportion. We have data to suggest how high that proportion is of people coming from other provinces just to get the normal services here and then return back to their province. And again, that is part of the equitable share formula challenge, because in the equitable share formula challenge, let's call it semigration, is not sufficiently covered in that equitable share. I raised it at the National Health Technical Committee meeting. Gauteng obviously agreed with me, because the issue is you can then say this is the population we get, and you get money according to the population. But our point is, if part of your population comes across the border just to get services, then that semigration is actually quite an important thing to measure in terms of building it into the refinement of the equitable share formula. Mr. Kay?
Yeah, so I mean, it's an incredibly valid question into the following financial year, because it didn't impact us in this financial year. But what I will say is that there's been a revision to the provincial equitable share formula, which has started to be phased in. And that revision of the provincial equitable share formula has changed the risk-adjusted factors that go into how the health's allocation is then sent down to the province. That includes population is one element, sparsity is another element, total fertility rate is a third element, and then premature mortality is the burden of disease element, and the last one is a multiple deprivation index. In other words, how well is the municipality doing in the local geographic area? That is 75% of the formula. And then there's the output component, which is actually the feed through doors. And so we will pick up people that are coming trans-border for the 25%. So if they're staying in a hospital, we will pick them up staying in the hospital. If they're coming into a PHC facility and they've come across the door into a PHC facility, we will pick that up, but only to the extent of 25%, not the 75%. The problem with the revision of the formula is that with bringing in the multiple deprivation and the sparsity, both Gauteng and the Western Cape have been adversely impacted to the benefit of the other provinces. And that is 350 million rand for us in the 23-24 year. And that is money that has been taken away from the provincial equitable share allocation. It is partially covered by the increase in the population, but not fully, because the provincial equitable share formula makes you a victim of your own success. Because the victim of your own success is it only funds us on uninsured patients. So if we have an influx of insured patients as a ratio and proportion, we get less money. There is also an undercount. So we are being allocated on somewhere around about 7.1 million people. It increases up to now 7.4 million per what the census results are coming through. But we won't see that benefit from an increase in our provincial equitable share until probably 24, 25. They will phase that in over a period. What we've done is we've deepened that down to a sub-district level, because the data is available at a sub-district level. So you then de-link the operational requirement and the budget that is allocated, because the budget that is being allocated is based on the population needs and the burden of disease within that specific geographical area, which may then be different to the adjacent one because of the various factors that have come in. And then the service that you have to render, the design is going to be different in geographical areas because you're having to respond to a different burden of disease. Now, obviously, there's a whole lot of complexity, and we can't just go in and do that as an instantaneous implementation. We have to manage that over a period of time, so as to responsibly not destabilize the whole platform. because that has the propensity to destabilize, and we're not in that game. We want to keep a stable system. So it's a very interesting question. There's a further problem in the output. My parting shot on this one, because in the output they take the PHC headcount, the primary healthcare headcount, which presupposes that people that are coming across your threshold are being counted. But that's not how we render a health service. We have chronic direct medication that gets sent to people's households. We have community health worker engagements, millions of them, with this express desire and goal to get people out of facility and to improve their service and their experience by receiving it at home. We don't get funded for that. So there is, I've called it the dumbness of the equitable share formula beforehand, because there are a whole lot of factors that are coming in that are impacting our ability to attract the budget that we should be for the services that we are actually rendering. Thank you, Chair.
Thank you, Mr. Kay. Thanks a lot. Could I just ask any other philosophical questions members like to ask? If not, thank you, Minister, and thank you, Dr. Kluter and your team. I know we can be immensely proud of your department. We are very much aware of the enormous challenges that not only yourself, but the thousands of fellow employees that fight the battle on the front line every day that they face, and Minister often sensitizes us about the challenges that your department experience on a daily basis. So from our side, and we want to continue wishing you the success that you've experienced thus far. Not only one unqualified audit, but 5th in a row, which is unparalleled. And we know that our healthcare may not be perfect, but it's in good hands. Thank you so much. Minister, if there's any closing remarks you would like to make?
Thank you. Thank you, Chair, and your team. Taking note that this is the last annual report for the term. So some of us might not be back next year. So therefore, I just want to thank the Auditor General, the Internal Audit Committee. I do know that in our quarterly engagements, sometimes I ask questions that are also beyond your control, especially when it comes to the PDOs, what they are trying to highlight, but it comes back to us, how we can be able to fix these things within a sector, which is what Member Nkonhlo was trying to highlight, that it's not necessarily when we say these are not kind of targets, they are wrong. It's about us, South African health sector. We need to fix those, because you don't need to do as many, but I did indicate that in some instances, because they are constitutional grants, they don't have other way to try to monitor. So, but thank you very much, AG and the internal audit. To the standing committee, both of them, I see also the chair from the health. Thank you very much for the opportunity, for allowing us not only to engage, but to hold us in terms of accountability. And thank you, Chair, for even chipping in. And then to the team, the best team in the country, I must say. Yeah, I worked in other provinces before as a health official. Thank you very much for what you do. Yes, indeed, it's not only about the audits, but we do know that you are also standing here on behalf of the whole other 34,000 staff members. It's not easy, and our journey throughout, it has always been not to separate the issue of the financing, the auditing with everything that is there. So looking forward for the next few months before we do the quarterly reports and also the budget, but as this is our annual last one. Thank you very much.
Thank you, Minister. Dr. Kluter, any final remarks on your side?
So yeah, thank you, Chairperson, and to the members. And thank you for the engagement today. I think it is very opportune and it's the right time. And I really like the transition of moving from accepting a clean audit should be a norm. And that we look at value for money and what the citizens' experience is. So thank you for raising those issues, because we would really, really like to engage in future in a very constructive way of taking that performance to another level. Allow me to say thank you first to the team of people that's here. As you can see, to drive down irregular expenditure, even with the definition down to 6 million, it is a massive achievement in this organization. There's many, many people in our organization that got to that point and continue to do phenomenal work for us to be able to achieve this really, really good results. But the big thing that I want to bring is this is a culture that you experience. When you engage the people here, hopefully you experience the culture of commitment, the culture of ethics, the culture of accountability. And then to our leader that's been with us for, she has been the longest serving MEC in the history of our department. So come April, May next year, it will be 10 years. And it's an achievement in our setting for somebody to reach that. But you can also see the manner in which she is, in a very mature way, nurtured us, supported us, guided us. She always liked to say that she is the pilot of the Airbus, and we are the passengers at the back. But really, I mean, just our sincere appreciation for this being a last, well, in this term, the last. Obviously, if you have to ask us, we would like her to stay with us for a long time. But just to really appreciate the leadership that we get from the MEC and the leadership that she provides not only in this province, because the leadership she provides nationally is very, very important. So Minister Mbombo, our appreciation to you. Thank you.
Yeah, thank you, Dr. Kluter. For those of us who want to delay joining the traffic out there are refreshments in the members' lounge, so you're most welcome to indulge in the refreshments that are available. And with that, members, thank you so much for your robust engagement. The meeting is adjourned. Thank you.